All right, everyone, let's go ahead and begin. Just so everyone knows, this meeting is being recorded, so please keep yourselves muted until it's time to speak. So welcome, everyone. Thank you so much for being here today for our third virtual Healthy Communities Coalition meeting. As a reminder, these meetings are every second Wednesday of the month at 10 a.m. Central Standard Time. And if you can't make a meeting, no worries. We always send out a meeting recording afterwards. Before we get into our agenda today, we wanted to announce that one of our team members, Connie, is leaving Healthy Communities for another career opportunity. We're very happy for her. She couldn't be on this call today, but that does leave us with an open position, a full-time position within our Covering Kids and Families program as an outreach and enrollment specialist that helps people apply for health coverage. We may have one more part-time position open up, and we will keep you all posted on that as well. If you know anyone who would be interested in the position, please let us know or encourage them to reach out to us. All right, so today we will have a guest speaker joining us later. So for the sake of time, we will do just some brief introductions. When I call on you, please tell us only your name and organization. And if we have time at the end, we will open it up for all of you to make any announcements. But if there is a time-sensitive event or announcement coming up that you'd like to share, please enter it into the chat box so we can all see it. Otherwise, you can email me any announcements and I will add them to our newsletter. So I'll go ahead and start us off. My name is Melina Rivera. I'm the Tobacco Program Coordinator for Healthy Communities of LaPorte County. Sue?
Good morning, everybody. Sue Reed. I'm the Executive Director for Healthy Communities. Thank you for joining us.
All right. The first person I see is Joaquima Doss.
Joaquima Doss with CareSource. I'm the Manager of Community Marketing.
Thank you. Grace, admin.
Yes. Hi, good morning, everyone. This is Erica Morse. I'm the interim program developer here at Grace and sitting in on behalf of CCH today.
Thank you. Dawn.
Hi, I'm Dawn Bila, Director of Aged and Disabled Services at Futures Case Management.
Thank you. Chantel Johnson.
Good morning, everyone. I'm Chantel Johnson, Community Relations Consultant with Anthem Indiana Medicaid.
Thank you. Beverly Millen.
Hi, can you hear me now? Okay,
Yes.
Is that better? Okay, Beverly Milan. I am with Beacon, and I am the Sickle Cell Care Coordinator for our program with North Central Indiana Sickle Cell Initiative.
Thank you. Raymond.
Yeah, I'm Ray Ginsberg from the Samaritan Counseling Center. I used to be a therapist. Now I do special projects and help our director and staff.
Thank you for being here. Dawn, oh, I already said Dawn. Denise.
Hi, I'm Denise Beck, and I am the community health worker with HealthLink in Michigan City.
Thank you. Ebony Neal.
Hi, good morning. I'm Ebony Neal. I'm the Family Resource Specialist for the Healthy Families Program at Doombrook.
Thank you. Hannah.
Good morning. My name is Hannah Malta. I'm the Outreach and Enrollment Specialist for HealthLink in LaPorte.
Thank you. Jennifer.
Which Jennifer?
Jennifer Heath.
Jennifer Heath, that's me. I'm Jennifer Heath. I'm the Foundation Director for Swanson Center.
Thank you. Juana.
Juana Ramirez, Member Connections Representative from Managed Health Services, Medicaid.
Thank you. Jessica Bamber.
Jessica Bamber with Caregiver Homes.
Thank you. Lacey Pullman.
Good morning, I'm Lacey Pullman. I am with Early Learning Connections through Geminis. I am the Community Engagement Specialist.
Thank you. Leah Hopper.
I am Leah Hopper. I'm the Executive Director of AIDS Ministries AIDS Assist.
Thank you. Marissa?
Morning,
Chad?
everybody. I'm a PNW social work student and an intern at United Way of LaPorte County.
Thank you. Melva Mayfield?
Hi, I'm Melva Mayfield. I'm a life coach with CareSource, and I'm the Northern region.
Thank you. Michael Jones?
Yes, Mike Jones here. I'm the Executive Director for Minority Health Partners of LaPorte County.
Thank you for being here. Rochelle?
Hi, I'm Rochelle. I am a nurse home visitor with Nurse Family Partnership here in LaPorte County.
Thank you. Susan?
I am Susan Enamorado. I work for Indiana Minority Health Coalition as a doula.
Thank you. Tamika?
Morning, I'm Tamika Saunders, Community Relations Specialist for United Healthcare Community Plan, Hoosier Care Connect.
Thank you. All right. I think I'm saying another name. Jamie?
Hey, what we doing? Introductions?
Yes, just your name and organization.
Jamie Fair. I'm the System of Care Coordinator for LaPorte County United Way.
Thank you. All right. So if you're new to this meeting, please enter into the chat box your name, email, and organization. That would be very helpful. Thank you all for introducing yourselves. Is there anybody I missed? Okay. All right. So first of all, I wanted to bring up our newsletter and give you an update on that. So you should have received the spring edition of our newsletter yesterday. This will be a quarterly newsletter. The next one will release in July. So if you'd like to add anything, please email me. And just to give you a better idea of what can go in it, you can include the services you provide, programs, events coming up, any agency updates, job postings, volunteer opportunities, and more. We really just wanted this newsletter to be a way that everyone can share information and resources and just get to know one another's agencies a bit more. So the next newsletter will release July 13th. And please send me any additions you'd like to add by June 29th. And I will be sending out email reminders about this as well. All right, so I also wanted to talk about survey responses. So last month I sent out a short 3-question survey focused on tobacco prevention and cessation in order to gain your input on a few topics to incorporate into our tobacco grant application. And I wanted to briefly summarize those results for you. There were 14 respondents. Thank you to those who were able to complete it. And just for some background, the state provides us with funding to do our tobacco work, and everything we do has to address the state's 4 priority areas of tobacco prevention and cessation. And so the state's 4 priority areas are: 1, to decrease youth and young adult tobacco use rates; 2, increase proportion of Hoosiers not exposed to secondhand smoke; 3, decrease adult smoking rates; and 4, maintain a state and local infrastructure necessary to lower tobacco use rates. So when we asked you all how you would rank these by importance, you said that decreasing youth and young adult tobacco use rates was most important. Increasing proportion of Hoosiers not exposed to secondhand smoke was second importance. Decreasing adult smoking rates was of 3rd importance, and maintaining state and local infrastructure was of 4th importance. So the state just wanted to know as a community how we view these 4 priority areas, as other areas and counties in Indiana may rank these differently. But regardless of how we ranked them, we will be addressing all of these in the work that we do. And just so you all know, this is how we ranked them in the last grant cycle as well. So the priorities within our county are staying consistent. On the survey, we you were also asked what are some ways we can strengthen our coalition's commitment and capacity to advance diversity, equity, and inclusion. And there were a lot of reoccurring themes in your responses. In summary, you all suggested to develop work groups geared to reach specific marginalized populations, develop specific marketing and outreach plans to reach marginalized populations and the organizations that serve those populations. Invite community members who have been disproportionately affected by tobacco use and secondhand smoke to join the coalition, and have diverse trainings and guest speakers come to help educate us on health equity and marginalized populations. So we are definitely going to be working towards these goals moving forward, and we appreciate all of your responses. The final question you were asked on the survey was just if anybody would be interested in reviewing our tobacco work plan before we submit it to the state. And we did get a few members willing to help, so thank you very much to those who helped us in that process. On that same note, I wanted to update you on the Tobacco Prevention and Cessation Grant. So we did submit that grant application on March 22nd. Again, thank you to those who helped us along the way. And we should be hearing back from the state regarding our funding in May, which we will keep you all updated on. All right, so I also wanted to bring up health equity. So the state's Tobacco Prevention and Cessation Commission, who provides us with funding to do our tobacco work, has announced their new strategic plan's mission for Indiana commercial tobacco control. And the mission is to achieve health equity by eliminating the disease and economic burden associated with tobacco addiction and exposure to commercial tobacco products. So they're really trying to focus more on health equity, which is great. And just so we are all on the same page, health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. And health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. So what tobacco-related health equity is the equitable, fair, and just opportunity and conditions for all people to live a healthy life free from commercial tobacco-related disease, disability, and death, regardless of their race, ethnicity, age, income, level of education, gender identity, sexual orientation, the job they have, the neighborhood they live in, the type of insurance they have, or if they are uninsured or underinsured, or whether or not they live with a disability or substance use disorder. So I just wanted to lay it all out there for you to make sure we're all on the same page. So the state recognizes that all Hoosiers are affected differently across racial, ethnic, and socioeconomic groups and strives to address those disparities. So the state is really emphasizing that their grantees, such as Healthy Communities of LaPorte County, approach their tobacco work with a health equity lens. And we are really excited to hone in on that moving forward. So with that said, I think that is a perfect segue for introducing our guest speaker to educate us on cultural competency, because without it, we will not be able to fully achieve health equity. So without further ado, I'd like to introduce Brenda Graves-Kroom, who is the Cultural and Linguistic Competency Coordinator for the Family and Social Services Administration within the Indiana System of Care under the Division of Mental Health and Addiction. So Brenda, if you have a presentation you'd like to share your screen, you can do that, and I'll pass it over to you.
Okay, thank you so much. So, as Melina was saying, my name is Brenda Graves-Kroom. I go by she, her, hers pronouns, Health Equity Director at the Division of Mental Health and Addiction. And I'm also a licensed social worker, LSW. And so My day job is working at Division of Mental Health and Addiction, and my evening job is I'm a therapist. And so I'm very busy, to say the least. In my state job, I do a lot of outreach work. I do lots of trainings across the state on cultural and linguistic competency. And I was involved with Indiana Systems of Care for about 5 years, and have since transitioned to mostly addressing more of our, I wouldn't say mostly, but really spending more time addressing internally how we're making changes at the Division of Mental Health and Addiction, DMHA, and then working with our contractors to be able to address the cultural and linguistic competency, or CLC, of our providers across the state. And so that's really exciting. So today what I have for you is a fairly quick, kind of quick and dirty sort of presentation that I had created for our staff actually a couple years ago, but all the information is still really relevant today. And so I thought that it would be helpful to share some of this information with you. So as you have questions or comments, feel free to go ahead and share those. I'm not really good at being able to see those comments and in the chat box and respond to those. So Melina, if those come through, feel free to interrupt me. I don't mind that. This will be a really informal kind of presentation. And, the more the discussion we can have, the better. Okay. So with that, we'll go ahead and get started. So the goals of this presentation are to demonstrate cultural and linguistic barriers with examples, define cultural and linguistic competency, address how exclusion happens and why it's harmful, address social determinants of health, such as poverty, define disparity and address how disparities come about, explain how the national class standards, culturally and linguistically appropriate services standards, address disparities and benefit the community. And then I'm going to highlight some plans for professional development opportunities. So some examples of cultural and linguistic barriers include an immigrant or deaf or hard of hearing person who cannot communicate with the reception desk of a provider. I used to work as an interpreter, and so I'm bilingual in Spanish and English. And when I was before my life at DMHA, I was self-employed, and I had a small business in which I taught Spanish and English classes. I conducted trainings on we used to just call them diversity trainings back then. And I did a lot of interpretation and translation services. And so when I used to work as an interpreter, I saw some very poor treatment of immigrants in that work. That was difficult to see. Another example is an elderly person who cannot navigate technological mechanisms to access needed information. And so I'm not talking about all elderly folks. My grandma, I can remember the first time I got a text message from my grandma, and she was in her 80s at the time. And so next time I saw her in person, I said, "Oh, I got that text message from you, Grandma," because I had never received a text message from her before. I didn't know that she would be able to really navigate these new phones. And she didn't used to have a cell phone. And so I said, "Oh, I got that text message. Did my aunt send that for you?" And she was very insulted. She was like, "No, I sent you that text message." So like, "Oh, I'm sorry, Grandma." But nowadays it seems like everything is online, everything is technological. And many people prefer to get their information on paper. I'm kind of old school. Although I'm online all the time, I like to have my information on paper too. So I have my notes right here that I'm reading from, as well as my presentation. So the next example is a person whose cultural beliefs and values hold them back from seeking needed services. And I think that this kind of runs the gamut of the possibilities of folks out there. I think about men, especially in the military, or I think of men of color, or I think of people of certain religious communities, for instance, the Amish or the Muslim community rather, when it comes to mental health. So when it comes to all of these different populations, specifically because I'm in mental health, I think about the cultural beliefs and values that hold folks back in these communities from seeking services in mental health and substance use. And then a person who feels restricted from seeking needed services due to social norms and stigma. I think about young people, especially in the LGBTQ plus community, and the needs that are there in the community. So what is CLC? It's behaviors and attitudes, as well as policies, practices, and procedures that enable effective work in cross-cultural situations. Culture includes language, traditions, histories, customs, beliefs, values, and much more. And so it's attitudes that promote CLC. They're ones that strive to be bias-free, that explore implicit biases as they arise to one's awareness. And so what is an implicit bias? It's the attitudes, the implicit attitudes, implicit stereotypes that we've learned over our lifetime that we may not consciously embrace. They're subconscious and they affect the way that we respond to people and situations. Cultural humility. And so there are folks who are in the camp for cultural linguistic competency. There are folks who are in the camp for cultural humility. But cultural humility is the idea that cultural competency is a lifelong journey and that we're never truly ever culturally competent, that we're always learning and we can always learn more about the people that we're serving. And so these are behaviors that promote CLC, cultural humility. They're bias-free as well. They're not acting on biases. They're also mitigating these differences, regardless of whether there's a bias there or not, that there are cultural differences, and we don't always know how to navigate those differences and be responsive in a culturally sensitive way to be able to gain trust, to be able to overcome stigma. And so is it possible for someone to be culturally and linguistically competent? Well, I think it's a journey. And so it's about being able to infuse our policies, practices, and procedures with CLC, cultural humility, within our organizations and within our systems and our institutions. So when providers do not continually address cultural and linguistic competency, then they cannot have full capacity to adequately serve their clients or consumers. Our world is continually becoming more and more diverse and complex culturally. It's influenced by politics, religion, technology, major events, for example. In addition, there are generational cultural differences. If we don't keep up with how to navigate our differences and mitigate the effects of bias and social determinants like housing, education, transportation, etc., then disparities will continue to become greater and worse. So individuals from social and/or cultural groups that are not in the mainstream of society are often not being served adequately. In addition, they are often not being served at all when they have a need. And the bottom line is that people are often falling through the cracks of our systems. Groups in society that experience the greatest disparities are those that also have the least collective wealth, power, influence, and resources in society. They often have experienced historical trauma that has been demonstrated by scientific research to transmit from generation to generation. And so I remember in particular reading about an experiment that was done with mice. And so what they did was they exposed these mice to an orange essential oil. And then as they would expose them to this scent, they would do a negative shock stimulus. So basically, I think where the mice would get a little bit of a shock, a bolt. And so then what would happen is that after having done this, when they would expose them to the to the orange essential oil, they would have a reaction to the oil without even having received the shock. And so this was a learned behavior as a result of the trauma that the mice had experienced by being shocked. And so we see the science of historical trauma. And so I think about the Jewish community and the survivors of the Holocaust, and the children of those survivors from the Holocaust are experiencing and have experienced the trauma of their parents that went through the Holocaust, even though they did not experience the Holocaust whatsoever. And usually they grew up in the US. And so the historical trauma is a very real thing that has been happening with so many different groups in society, and often groups of color. So how exclusion happens. Numerous social and/or cultural groups have significant differences from the mainstream that cause them to be marginalized in society. Exclusion leads to ethical and legal issues, costs to the community, and it leads to health disparities. And so the cultural differences are often the target of disapproval, especially when values and beliefs are involved. This is exacerbated when biases are involved. And the systemic racism and other isms, sexism and et cetera, homophobia, et cetera, are often why groups of people in society are isolated, segregated from the mainstream, and oppressed. And it can be often unintentional that they get excluded, because our systems usually aren't proactive about addressing biased policies that have been put in place however many years ago. And so a policy that may seem race neutral on the surface can actually have a great impact on oppressed groups in society if we're not proactively looking at what is the impact going to be on communities of color, on folks who have lower socioeconomic status. So in addition, these groups experience disadvantages or less opportunity in comparison to others, and are often affected more often by social determinants. Social determinants of health are things like housing, food availability, transportation, environmental factors, and so on. When people don't have adequate housing, they live in food deserts, they can't access transportation as needed, and are exposed to violence and crime in their communities, they are likely to suffer from chronic stress and trauma, and oftentimes racial trauma, just the same as if they experience racism, sexism, et cetera, and in general, injustices and oppression in their environment every day. And I think I saw the chat box lighting up. Do we have any comments or questions coming through?
No, nothing for you, Brenda.
Oh, okay. All right. All right, very good. Well, I'll pause here in case there is anyone that wants to make a comment or ask a question. It's a lot of information, and it is a bit daunting to really face what's happening in society. And I'm going to show you some statistics that are going to probably be difficult for you to see. And as we're talking about this subject, it can be a highly emotional, You can have a whole set of emotions that you experience. And so as a licensed social worker and a therapist, I would encourage you to do deep breathing if you're triggered at any point with the presentation, with the statistics that I'm about to show you. And it's that belly breathing, you know, from the belly, and really taking like 4 slow, deep breaths and then exhaling for 4. So this particular statistic is from the Indiana Youth Institute, and they have a kids count data book that I'm sure you're all familiar with. I would imagine you've seen the statistics for your counties. And so as I had told you before, this presentation is a couple years old, and so the data is old as well. If I remember correctly, it's from 2018. And so what we see here is that Black Hoosier children are nearly 3 times more likely to be in poverty than their white peers. And this was from actually 2017, the Child Poverty by Race and Ethnicity, Indiana versus the US. So you see on the left, the aggregate totals, how Indiana compares to the US. So Indiana is the purple, the US is kind of the light blue. So when we look at the aggregate data, it doesn't look like Indiana is very much less off than overall in the US. But that's why it's important to have disaggregated data. And so as we look at the disaggregated data and we make this comparison, you're going to see a big difference. So as we look over to the next line graph, we see that for Indiana, 14.6% of white children are living in poverty compared to 18.4% in the US. Then you go over to the next line graph, and what you'll see is that in Indiana, 40%, as of 2017, 40% of Black children were living in poverty as compared to 33% in the US. So we see a significant jump. And then the last line graph, we're looking at the number of Hispanic children in Indiana at 28.3% compared to the US at 26.3%. So significant disparities that are happening there. Now go to the next slide. So when we talk about inequities, it's these inequities that contribute to health disparities. It can be inequities in social determinants and education, et cetera. And so the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health because of social disadvantages. So, and I would add discrimination and stigma as well. And actually the CDC has recently updated what they say in regard to disparities. There was an article that came out on April 8th of this month. So, and it talks about, the title is CDC says racism is a serious threat to public health. Racism is operating not only with respect to COVID-19, but also with respect to infant mortality, maternal mortality, obesity, said a past president of the American Public Health Association. Confronting the impact of racism will not be easy. And so the CDC is the latest and largest US-based health agency to single out racism as having a profound and negative impact on communities of color and contributing to disproportionate mortality rates of people of color. So the opposite of disparity or inequity is equity. Health equity is when everyone has a fair opportunity to achieve optimal health. It means that one size does not fit all. Different people need different things, and blanket approaches to serving people means that people fall through the cracks. And so basically what I'm referring to here is we can have universal approaches and we can have targeted approaches, and you need both. You need the universal approaches that are going to appeal to the masses, to everyone, but then at the same time, to all of your community. But then at the same time, you also need targeted approaches. And those target approaches are going to take into consideration the different populations that exist within your community. If it would take, for instance, into consideration language differences when you're dealing with immigrant and refugee populations, just as one example. And so we need both those universal and the targeted strategies in our outreach if we're to be successful in decreasing disparities. So health disparities result from multiple factors, including poverty. I grew up in poverty, and what we experienced was that life's about surviving from week to week, and health isn't as much of a priority. I can remember, I think, going to the dentist maybe a couple of times when I was a kid, and that was only when there was a problem. And so statistics show those who live in poverty also have a shorter lifespan. And so you can see significant differences city by city as you look at the area. So for example, if you look at the city of Chicago, you're going to see that people that are living in northern Chicago are going to be living 5 and 10 years longer, sometimes longer than that, than those who are living in southern Chicago. Environmental threats such as violence, crime, and poor housing, inadequate access to healthcare, lack of insurance, lack of providers in the area to be able to serve all those who are in need. As a therapist, I am constantly receiving calls from folks who are experiencing depression and anxiety and post-traumatic stress disorder. And I don't have the capacity to be able to serve everybody. And there are a lot of Spanish speakers that are calling. And there are not enough Spanish-speaking therapists in the state to be able to address all of the need that exists. But I'm just thankful that we're seeing more people from the Hispanic Latino community that are reaching out for help, because oftentimes mental health is so stigmatizing for folks. Individual and behavioral factors. So speaking of that stigma, that internalized stigma that comes about based on the messages that folks are hearing, that they hear from the media, they hear in society, and that often becomes internalized. And we talk about internalized racism and internalized homophobia, et cetera. And then there's the historical trauma as well. And so these are all factors as providers we have to take into consideration as we're trying to outreach folks, as we're trying to engage folks in services and overcome mistrust and stigma. And then there's educational inequities, disparities in which students get designated special education and often have inequitable instruction. I had at one time a young person as a client with a cognitive, it was intellectual developmental disability. And she had always been in what she said were normal classes. And all of a sudden, going into high school, she was placed in a special education classroom, and it was especially difficult for her. And she said all she wanted to do was go back to the normal classroom. And so being able to work with her and help her to overcome those difficulties and the last time I spoke to them, the mom had been advocating to get her child out of the special education classroom, but the school was saying, okay, well, that's not really how it works. We have to do this series of testing in order to be able to know that she's okay in going into a normal classroom. And so the last time I spoke with the mom, the daughter was still in the special education classroom and really struggling to be motivated in school. And so basically where she was experiencing other students who were constantly screaming and disruptive to her education. So that was really hard for her. Students who are getting suspended or expelled from school, who are not able to graduate, who are not able to go on further to job training or higher education. So as we look more at health disparities, here are some more statistics from IYI. Hispanic high school students are more likely to report drinking alcohol in the past month, 25.2%, compared to white students, 21.9%, and Black students, 19.1%. And marijuana use is lower among white Hoosier high school students, 11.8%, than it is for Hispanics, 16.5%, and Black students, 20.2%. Hispanic high school students, 37.2%, are more likely to report feeling sad or hopeless in the past year than Black, 28.9%, white, 33.1%, and all other students, 35.4%. So that would be that last statistic would be the aggregate. And so these statistics are sad for all involved. And we want all to do better and have better outcomes. Yet even worse, the numbers for Black and Hispanic students are disproportionate to their representation in society. And so just one more statistic here. Youth who identify as lesbian, gay, or bisexual are 5 times more likely to attempt suicide. This is the percentage of high school students with suicidal ideation. So they've had thoughts of suicide or they've actually attempted suicide. Bisexual orientation, this was back in 2015. So that first line graph, you see that the light gray color or the light blue color is heterosexual students, high school students, and then the dark blue are gay, lesbian, or bisexual high school students. So you see the difference between heterosexual at 15.2 compared to 46.4% of gay, lesbian, or bisexual that seriously considered attempting suicide. The next line graph, heterosexual is 13% compared to 42.8% who made a suicide plan. The next line graph, 6.8% as compared to 34.2% who attempted suicide. And then the last line graph, 3.0% as compared to 11.1% suicide attempted and treated by a doctor or a nurse. And so I would encourage you to check out IYI's latest Kids Count data book for 2020. You can find that online to see the latest developments with these health disparities. So that's a lot of information. And when I talk about this subject, it's emotionally charging for me. I always end up leaving a little bit of myself emotionally with this subject because it's so difficult. And so I just have to take a second, take a deep breath myself. But knowing that I feel hopeful because we are working on these issues and we have a framework to be able to address so many of these health disparities. And that framework is class standards. So fighting health disparities is possible with class. The national standards for culturally and linguistically appropriate services. And this is a set of 15 action steps intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services. And this comes from the Office of Minority Health. So most of the standards are recommendations, but those standards that have to do with language and communication are requirements for all providers receiving federal funds. It is a requirement they have a language access plan. And this is a policy that outlines how limited English proficient individuals will be accommodated, or low literacy individuals, with language services at no cost to them, whether that's an interpreter, whether that's material and they're translated into their language, et cetera. So at DMHA, we have a strategic draft plan for implementing CLAS internally, and then also externally with the providers who we fund. And this is across the state. And we have a contract with, so we basically kind of what happens, if I could put this in really simplistic terms, is that we're funded partially by state funding because we receive federal funding. So we have to match the federal funds that we receive with state funding, but a good majority of the funding that we get comes from our federal provider, from SAMHSA. And so I always, when I'm trying to think of what SAMHSA stands for, I always forget Substance Abuse Mental Health Administration. I had to think about it. And so we receive funding in the form of block grants that go to providers across the state. And we are looking to find ways to be able to provide more opportunities for BIPOC communities, Black, Indigenous, and people of color to be able to access these funding sources. And oftentimes their grants, their requests for it starts off with like a request for a proposal or a request for funding. And so being able to incorporate language within these contracts to address disparities is one of the things that we're looking at, to be able to address disparities, to increase the number of contractors who are represented within the BIPOC communities. Those are just a few things that we're doing. We're discussing and planning how we can be more inclusive of all groups in the state and how cultural diversity of the state impacts our work. And so just recently, well, let me go on to another slide before I talk about that. Here are some of the opportunities for professional development. We have 12 trainings per state fiscal year. There are 4 in person by region, and actually 5 technical assistance online, or 5 webinars. That's changed since I created this. We are examining, with that contract for cultural competency across the state, we're examining current practices, policies, and procedures within agencies, organizations as they relate to CLC and CLAS, providing technical assistance on specific issues relating to the incorporation of health equity principles into accessing care and CLC into treatment services. Potential audiences have included community mental health centers, system of care groups, peer supports. So the peer supports are the folks that have lived experience with substance use and who are able to outreach and engage folks with substance use disorders. Community health workers. I used to be a bilingual health outreach worker with our local Minority Health Coalition. That was fabulous work. Our OTPs are opioid treatment providers, and family and youth that are involved in the system. And then we have our annual Cultural Competency Conference. That's coming up on May 18th and 19th. And I can get that information to Melina. It is free. It's a virtual conference. Anyone is invited to register and participate in that conference. Last year, we had a fabulous conference and lots of great positive feedback from that conference. And so some of the things that I wanted to talk to you too about was so I mentioned the grant writing, the block grants. We are in the process at DMHA of, so we have a CLC and Health Disparity Committee, but we've just recently changed the name to Health Equity Committee. And so this Health Equity Committee has been meeting for several years now, but it's really gotten a lot of momentum in the past year or so. And so this particular committee, we have representation from all teams within DMHA, and DMHA is probably about 60 folks or so. And so we have folks that are representing our mental health youth, our adult mental health, our substance use, addiction, and then also with our leadership. And so we have, so some years ago, I had written a policy for cultural linguistic competency for the division. And so that went through approval process, and that was approved as our first policy that we had, but basically emphasizes the need for cultural and linguistic competency within our practices and our procedures. It states the need for annual trainings for staff. It states the need for addressing health disparities within our contracts and making sure that we have language within those contracts. And so we're actually going back and we're revisiting that policy this year, and we're adding new language to address systemic racism as well. And so being able to address systemic racism with our providers across the state is very important for us. Some of the staff trainings that we've done in the past is we've had cross-cultural simulations with staff. We've done a poverty simulation with our staff and with the employees of FSSA. And we're really excited to have Dr. Brianka Merritt, who is our relatively new equity officer for FSSA, who is addressing health equity for all of the divisions under Family Social Services and Administration. So we have some really exciting things that are going to be happening, and so you'll see, I think you'll see the impact of that locally as well in the year and next year to come. We have a strategic plan for addressing the health disparities. There's oversight of our providers. So all of our community mental health centers around the state, asking them about what is their plan for class standards? Do they have a language access plan? How are they addressing disparities? So that's just a little bit of everything that's going on. So I know I said a lot. I'm going to stop here, pause, and take some time for questions and comments.
Brenda, I don't see any specific questions in the chat box. You are getting some thank yous from folks. Thank you for all the examples. It really adds a human touch and helped me understand the statistics. Very informative presentation. So we're getting a lot of thank yous. Are there any questions that we'd like to ask Brenda? Yeah, go ahead.
I was going to say, I don't mean to put you all on the spot, but how could the Division of Mental Health and Addiction assist your coalition in addressing disparities?
I mean, presentations like this are always very helpful. We are just starting these conversations on cultural competency and health equity. So thank you for kicking us off in such a thoughtful way. Does anybody else need assistance or have any input?
And we are here too if you want to pick our brains. We've been doing that recently. We had providers reach out to us that are having difficult situations happening. And so if you want to pick our brains, or we can invite you to participate in different meetings, you're most certainly welcome to do that as well.
Thank you for sharing all those great resources. We really appreciate your time.
Yeah, you're welcome.
All right. All right, I don't think we have any other questions. Brenda, if you'd like to hop off, again, thank you so much for your time.
You're welcome. All right, everyone, take care.
All right, everybody, in closing, I did want to let you know that I will be sending out a survey to you all just to get your contact information so that I can put it all on one place, and I can send it out to the entire coalition so that if you have questions for other coalition members, you can then just look at the list, email them, call them, whatever. So be on the lookout for that, add your contact information, and I will send it out to everybody. And then our next meeting is Wednesday, May 12th at 10 a.m. So I hope to see you all there. Thank you all so much for being here today. And that's all I have. Have a great rest of your day.
Thank you.
Bye.
Bye-bye.
Goodbye all. Thanks again.